All right, well, we're here. We've got Dr. Neil Christie and Dr. Krish Fernando, myself, Dr. Stephen Hazelrig, to talk a little bit about varying topics, but addressing specifically how we look to the future in managing some of the lung cancers, the smaller lung cancers, and specifically how some of that will relate to some of the newer radiation techniques we refer to as SBRT. So, Neil, your institution has been a little bit of a leader in some of this area, so maybe you can start out and tell us sort of how this SBRT program has worked at the University of Pittsburgh, and maybe specifically talk about how thoracic surgeons can get involved.
Yeah, well, we had University of Pittsburgh was a leader in stereotactic radiation for brain tumors. Dr. Lunsford had brought that technology back from Sweden. And that was driven by surgeons in addition to the radiation oncologists. So we kind of took that as a model when they developed the new techniques to accommodate for extracranial motion, and now that we're able to do body radiotherapy. So we had some of the early technology, and we were involved right from the start. And basically we wanted to model our practice after the neurosurgeons being involved with the radiosurgery. And we felt it was appropriate as thoracic surgeons. We were the ones that had been involved with the potential curative therapy for stage 1 lung cancers, and if it was a new technology, we thought we should be involved with that as well. So it has been a very good collaborative practice. Our patient population right now is we've been treating clinical stage 1 patients that we feel aren't operative candidates based on lung disease and comorbidities, but we've been able to make sure that they're appropriately staged, and we've had follow-up with the imaging, with the medical oncologist. We've been able to, or the radiation oncologist, we've been able to look at our outcomes. So, and as we're moving forward, hopefully into clinical trials to see who might be good candidates that are operative candidates, I think we're in a good position.
Okay. I think most of us are in agreement, or all of us are in agreement, that for the non-operative patients, the SBRT has been a nice modality and a good way to treat smaller lung cancers. There are some other options to deal with some of those, and Christian, I know you've had a lot of experience in that. Maybe you could address some of the other methods.
Right. So really what we're talking about is ablation, which has initially been done percutaneously. And the first of these modalities is radiofrequency ablation that uses an alternating current that goes between a generator, the patient, and then dispersive electrodes on the patient. There are other technologies as well, microwave and cryotherapy, and also another newer technology called irreversible electroporation, which utilizes a direct current. The thing with radiofrequency ablation is that for the most part this is done by radiologists because it's using an image-guided approach with CT. And there are surgeons who have learned how to do this and have access to a CT scanner and can do this technology. But for the most part, it's been undertaken, I would say 80%, 90% of cases are done by radiologists. And so the studies for RFA are not quite as good as the SBRT trials. But I will say that if you look at actual survival, in medically inoperable patients who've been treated with SBRT and who've been treated with RFA, the results are exactly the same, to be quite honest. And so, probably the most important study for SBRT is RTOG 0236, which was a 55-patient study, had 3 years. It was about 55% survival in that study. Recently, we had presented the data from a multi-center RFA study, which is sponsored by the American College of Surgeons Oncology Group. We looked at 2-year survival, and again, it was a 55-patient study, and 2-year survival was about 70%. Local recurrences are higher with RFA than reported with SBRT, but I think the problems are in the way that the local recurrences are defined, and also in the way that they're looked for as well. So in the RFA trial, we use CT scan, we use PET scan, we use something called CT densitometry, and we also liberally used biopsies as well to look for local recurrences. In most of the SBRT literature, they typically just use CT scan and look at images from the CT scan, and rarely use PET scanning in that. So you have another modality that I think is equivalent in terms of survival. It's not used as much, and but I think it's challenging because we do have something that I think can work. Coming down the pipeline, we're going to have the ability to navigate with a bronchoscope and place probes into lesions bronchoscopically. I think this will open up a new area of investigation. It will open up these therapies to surgeons and to interventional pulmonologists. So we'll see some disruption in the way things are done in the future.
So Neil, you have most of those modalities available in Pittsburgh. Do you use anything else in the inoperable patient, or is SBRT dominate?
I'd say the majority of the patients are treated with SBRT, and part of it is the referral patterns. I would say, at least in Pittsburgh, the perception of the referring doctors, the medical oncologists, the pulmonologists, is that SBRT is superior, but we certainly have a lot of experience with radiofrequency ablation as well. And as Christian said, the survival is similar. I think we probably have better data for SBRT, and going forward, and again in terms of the long-term outcomes, my suspicion is that it may be better for SBRT than it is for radiofrequency ablation. But I'd say because of referral patterns, the majority of the patients in Pittsburgh are getting SBRT, but we do treat patients with radiofrequency ablation as well.
Yeah. If I can interrupt, I think that there are other factors that come into play as well. I mean, as I mentioned, most of the RFA is done by radiologists who typically aren't stakeholders in the care of cancer patients. When you have SBRT, this is driven by the radiation oncologists. These doctors come to the tumor boards, they see the patients, and plus from an institutional standpoint, you have a lot of investment in buying an SBRT machine, and also the reimbursements are much better for SBRT. So there's a drive, I think, financially to treat patients with SBRT rather than RF. And I think that also the folks who are actually doing it are the ones who are seeing cancer patients. And as a result, I think that's also reflected in the fact that the studies that are out there are more mature with SBRT and better with SBRT as well than they are with RFA. But I think that plays into the whole equation.
So I think one of the concerns is what the future holds, not with the inoperable patient, but instead with the operable patient, the patient that can tolerate a lobectomy but has a small, let's say less than 2 centimeter lung cancer. Maybe each of you can give your opinion on what you think the data would suggest today, and maybe give us some futuristic ideas of where you think things may be going.
Yeah, well, I'm happy to start. I think that whatever ablative therapy you have, whether it's stereotactic radiation or radiofrequency ablation, by definition is a very focal therapy. And Chris was quoting the RTOG study. They find within the radiation field, the focused radiation, the local control rate's about 97% at 3 years. So that's very encouraging, but it is a very focal therapy, and I think we have a lot of data, surgical data, looking at the outcomes of lobectomy versus sublobar resections. And I think everyone would agree that stereotactic radiation would be more akin to a sublobar resection. Whether it's more like a wedge resection or a segmental resection, it's hard to say, but it certainly would not be equivalent to a lobectomy. And we have pretty good data for tumors that are over 2 centimeters or certainly over 3 centimeters, that the outcome with limited operations are inferior to that with lobectomy, the most common study being the lung cancer study group. So I think that as far as curative therapy in operative patients, based on the data we know from limited surgery, it does not make any sense that stereotactic radiation is going to be equivalent. I have to say, myself and others have been surprised at the outcomes, at least in in case comparative studies and even propensity match studies that actually the outcomes with stereotactic radiation are better than one would expect. Some people have speculated that there may be some degree of radiation, some limited degree of radiation that's treating the nodal fields. I'm not sure, but I think it's going to be very important that we have prospective studies looking at stereotactic radiation versus surgery, and I think it may prove to be equivalent in small tumors, 2 centimeters or less, that have been very carefully and appropriately staged. Tumors larger than that, based on the surgical data, it doesn't make sense to me that it would be as effective, but I think the studies will tell, so I think it's very important that we go forward with some prospective studies.
Okay.
Yeah, I think that there's a real danger because when you look at abstracts and you see what the SBRT literature shows, and you do a quick interpretation of the abstract and you see local control in one and local recurrence in another, and the definitions are completely different as in surgical literature and in the radiation literature. And so what happens is that there's some misinterpretation by some of the radiation oncologists that SBRT is equivalent to lobectomy, and it isn't equivalent to lobectomy. There's interpretation that it's equivalent to sublobar resection, and I don't think that that's the case, and I think that a trial will show that, but we have to do those trials. I think one of the problems also is the initial RTOG trial looked at earlier follow-up on those patients, but then as they followed the patients a lot longer and they had their 5-year follow-up, which was recently presented at the ASTRO meeting, their recurrence rates went up and their survival got a lot worse in those patients. And so that data still needs to come out and be published. I also want to mention Z4032, which was a trial that was done again by the American College of Surgeons Oncology Group, and it looked at sublobar resection. And in that trial, we were treating higher risk patients who we didn't think would be candidates for lobectomy. And our 3-year survival was about 70% in that, and our overall local recurrence rate was about 12 to 13%, lower than in some trials reported with wedge resection. If we used what we call it local progression, which is recurrence immediately adjacent to your staple line, which is very similar to the recurrence rates of local progression that were reported for SBRT, our local progression rate was 5%. So we have exactly the same local progression rate as the SBRT folks have, and we have a better survival at 70%. So I do believe that sublobar resection is the standard of care for a higher risk patient who can't tolerate a lobectomy. And I think that before SBRT becomes adopted as a standard of care, we need to do some kind of a prospective trial and compare those two modalities.
Yeah, I would agree, and I think just to echo that, in the lung cancer study group, one of the main outcomes was the local recurrence in the lobectomy group was about 6% versus, I believe, 13% with the sublobar resection. And in the RTOG trial, they did break it down into recurrence within the PTV, the area of radiation plan, local recurrence within the lobe, and then recurrence within the hilum. And if you add those three up, it comes up again to about 13%, which is comparable to what we call the local recurrence in the lung cancer study group study, which is much higher than the 6% in the lobectomy group. The other thing is this Timmerman's RTOG study that we've been referring to was confined to tumors that were the optimal tumors, more than 2 centimeters from the lobar bronchi, the peripheral tumors that were getting treated with the 58 to 60 gray, that we don't know the outcomes haven't been so well defined for the more central tumors within 2 centimeters of the lobar bronchi, where we feel we have to get a lesser dose, and that I think is not always appreciated as well, that this Timmerman data that we have so far is really limited to the optimal tumors.
One of the other criticisms of the SBRT has just been a lack of complete or consistent staging of the patient as opposed to surgery where hopefully nodes are taken and a little better staging's done. Maybe each of you can comment on that aspect of it and how maybe in your program or what would be ideal in terms of trying to stage patients that are going to get SBRT.
Yeah. Well, again, I'll start in our program. all the patients that are potential radiosurgery patients are assessed in a clinic with a thoracic surgeon and a radiation oncologist. So I look at their staging just like I would for any other patient that I was considering doing an operative intervention, although it's a little bit different. If I'm considering doing a lobectomy, I want to make sure that they don't have central mediastinal disease, because I think myself and others would generally acknowledge you're better treated at least with induction chemotherapy, if not definitive chemoradiotherapy. And we don't rely just on the CAT scan or the PET-CT scan because of the concerns of false positives and false negatives. So, we're prepared to stage those patients. If a potential surgical patient has N1 disease, that can be addressed at the time of surgery with the lobectomy. But if a patient has clinical stage 2 disease, it's really irrational to treat them with stereotactic radiation. So again, that needs to be addressed, and at least in our division, all the surgeons do endobronchial ultrasound biopsies, navigational bronchoscopy, so we're prepared to do surgical staging. So we would evaluate them just as we would for a surgical patient. Even more so, if there's a question of hilar disease, we need to ascertain that with an EBUS and a biopsy, because that would rule them out for stereotactic radiation.
You have any comments about it?
Yeah, so I think that what we do now for the high-risk patient is one thing where I think it's reasonable to evaluate the patient with CT and PET, ideally get a biopsy, and then go ahead and treat, knowing that you'll have an incidence of occult nodal disease. If at any point we do go into lobectomy types of candidates and we move into that era, I think we will have to do mandatory EBUS or mediastinoscopies on those patients. I think that there is an incidence of occult nodal disease. I think it's about 15 to 16%, and I base that on two studies. One was a study that was published by the group from Baltimore, by Bill Krimsky's group. And what they did was they did an EBUS on every patient that was clinical T1N0. And what they found was a 16% incidence of occult nodal disease that they would never have identified in those patients because they went after that. And then another study that our group published from Boston University, we utilized PET scanning routinely in these patients. That's not part of the RTOG protocol for following patients. But what we found is we utilized PET scanning in the post-op period. We actually found about a 15% incidence of biopsy-proven N1 or N2 disease in those patients in follow-up. So these were patients who probably had N1 disease that was present beforehand, or N2 disease, and then became manifest during that follow-up period. I think that you're going to get failures for those reasons. Now, I think, again, in a high-risk patient, I think we can base it on clinical staging, treat with a modality. But I think that if we ever do take this to patients that we would treat with lobectomy, then we have to do mediastinal staging on those patients.
Okay. With regard to a lot of surgeons are interested in how best to get involved in an SBRT kind of program. I know that you have already evolved to that, but maybe you could comment on two aspects. One, what would be ideal in terms of a setup to evaluate patients for deciding the best treatment, and then second, maybe some suggestions for how surgeons that aren't involved now but would like to might get their foot in the door.
Yeah. Well, I think that how we work at the University of Pittsburgh is that we have a lung tumor radiosurgery clinic that's attended both by a radiation oncologist and a thoracic surgeon, and we have a half day every Tuesday, and that allows us to see new patients and assess them, make sure they're adequately staged, look at the patient characteristics, the tumor characteristics, and do we think if they have a clinical stage 1 lung cancer, are they best treated with surgery or stereotactic radiation? And our feeling is that surgical approach, as of right now, is the gold standard, that treating with stereotactic radiation may be appropriate based on comorbidities, but we feel it's an oncologically compromised treatment. So having that clinic and seeing the patients together, it's very convenient for both myself and the radiation oncologist and the patients, and the referring doctors like that a lot. We both see them. I do a consultation, they do a consultation. We're able to review all the imaging together and make decisions, and then if other staging or other testing is required, that can be done. We see all our follow-ups together as well, which has been very good as well. We've been able to follow those patients. We've done many publications looking at our outcomes. And then the other component for surgeons, in addition to the consultative work, it is recognized in the CPT codes that there is a code for the thoracic surgeon for the to do radiosurgery, and it incorporates doing the contourings or delineating where the tumor is. So there's a computer planning system for radiosurgery. I took the course for it. I'm qualified to do that, and I delineate the tumor. It also requires you to be available at the time of treatment delivery for confirmation of tumor location if required, so we always make sure that we're available at the facility for that. So that's how we work it, and it stems from having a very good relationship with our radiation oncologist, and the fact that we've been reviewing patients together at Tumor Board for many years, and it works out very well.
So the model that we have is that we'll place the fiducials, and usually that's done with navigation bronchoscopy. We have a tumor board that we do work together, and then our radiation oncologists and our thoracic surgery, we see patients in the same cancer center on the same day, and we're just a floor apart, and we'll go upstairs or downstairs and visit each other's clinics if we need to. And then as a surgeon, we'll also participate in the contouring as well. And so we get involved in the contouring, and then the follow-up again is done together, and so we coordinate that.
So, I mean, it sounds like, and I would say that having multidisciplinary conferences, involvement where everything is reviewed, consults are done, is the ideal, because we all know there are some patients that are good candidates for each of these different types of therapies. What about, I mean, for the surgeons that aren't involved now, particularly maybe those that are in private practice settings, do you have any tips or suggestions for them if they want to get involved?
Yeah, well, I think that if they're involved with a tumor board, presenting cases or in being involved in initiating that discussion, I think would be helpful. And I think being a thoracic surgeon, being aware of the treatment and what the outcomes are and what the limitations are, and being able to discuss that with some authority, I think that's necessary as well. And just being aware of this new technology and the importance it is for treatment of lung cancer. Because if thoracic surgeons don't do it, I mean, you could have an interventional pulmonologist that is able to theoretically assess operability of a patient based on, at least on their pulmonary status, has the ability to do endobronchial ultrasound, navigational bronchoscopy, place fiducials. They're able to do that CPT code billing as well for delineation of tumor and being available to confirm the targeting. That CPT code isn't designed expressly for thoracic surgeons. In fact, there's some talk about it in the radiology literature as well. So I think it's a matter of realizing it's important. It's going to be an important part, at least, of a treatment of a subset of lung cancer patients. And as thoracic surgeons, we should stay engaged with it. And if we don't, other people will, like the pulmonologist. They may take over that role for us.
Right. And there's certainly some hospitals where the SBRT is done in conjunction with IP, interventional pulmonology, and radiation oncology, and so the surgeon isn't really even involved in that, and so it all goes down to how you make relationships with other referring docs, or what your input is in the multidisciplinary tumor boards, and then and I think it's the challenges of building any practice in a different environment, but you have to work collaboratively, I think, with folks if you want to be involved in that. And you need to be involved in the decision about whether the patient goes for surgery or not for surgery, and we need to maintain that ability rather than someone else making that decision for us.
I think we all feel that the surgeon obviously has the best idea who is and isn't a good candidate and what the risks are involved, and so I think we feel like we should be the ones that decide if they're really an operative candidate or really not an operative candidate.
Part of the role, I think, because in this combined clinic at University of Pittsburgh, we have surgical residents down there and surgical fellows, and we have radiation oncology fellows as well. And there's an educational point on their point as well. And when, for instance, I bring up the point if someone has a right upper lobectomy with poor lung function, we have some data that their post-operative pulmonary function may actually be improved. That's a total novel concept to them. And again, I think these radiation oncologists that I work with and the trainees coming through appreciate it's not a straightforward thing determining who is an operative candidate and who isn't. And I think in the whole scheme of things, I think that's probably where I bring the most to the whole process. They don't really need me in terms of outlining the contouring. I think we bring a lot as well as in terms of invasive staging as well.
If you see a new patient, Chris, who's you don't think can tolerate a lobe, has a peripheral lung lesion right now that's a non-small cell lung cancer, what's the thought process you go through now, and how do you treat them?
So I look anatomically where I think the lesion is, and also assess the physiological status just as you would generally. And if I think I can do a wedge resection or a segmentectomy in the patient, I will usually discuss all three options with the patient and explain a little bit about each of the therapies to the patient. And you'll find some patients who will select a therapy and other patients who want you to select the therapy to them. And if I'm concerned about things, sometimes at least being a surgeon who can offer RFA and offer SBRT and offer surgery, I'm in a good position when I meet with the patient, and I can discuss all three options with them. And then I'll involve the oncologist, or maybe involve the primary folks if there are other issues that I'm concerned about.
Okay. Any different for you?
No, I think that it's, as Chris said, if the patients can perceive, if you can, obviously you have experience with surgery, if you have experience and you know about stereotactic radiation, I think it gives you a lot more credibility. And as Chris said, I think there's tumor factors. Some tumors are clearly better for surgery versus stereotactic radiation within the spectrum of stage 1 lung cancer based on tumor size, location. And then there's patient factors based on age, pulmonary function, comorbidities, and just functional status. And so it's a sliding scale. Everyone knows there's no patient that's clearly an operative candidate, or what I might deem as an operative candidate, someone might say is not an operative candidate. And I think in the end, I think we're obliged to let the patient know as well, because they're the ones that have everything at stake. And I find often they have strong opinions one way or the other. That I think absenting a prospective trial telling us where the pulmonary impaired patient, whether a segmental resection is better than stereotactic radiation, I could go either way. So I think it's good to give the patients that information as well.
Well, I appreciate your involvement. I think one of the take-home messages I'd like to have, at least until we get better data, is that for the patient that can tolerate a lobectomy, we still think that is the gold standard, and at best, SBRT is another type of a sublobar type of treatment, and I think that's important until we get other information. But I appreciate your time here today. Thank you.
Thank you very much.
Thank you.